Good morning. I'm happy to announce today's lecture on vascular access for hemodialysis will be presented by a senior resident, Richard Sousa da Silva. Please enjoy.
Good morning, everyone. I'm happy to welcome you for my today's talk about vascular access for hemodialysis. Thank you for the introduction. The talk will be divided into indications for hemodialysis. We will talk about central venous catheters, arteriovenous fistulas, arteriovenous grafts. Then we will talk about complications, and I will show you a quick systematic review and meta-analysis. First, can any resident tell me an urgent indication for hemodialysis?
For example, an intoxication.
Yes.
Or acidosis.
That's right. You have the vowel rule that helps you to memorize. It's A, E, I, O, U. A stands for acidosis, pH below 7.1. E for electrolyte disbalance, for example, or plasma potassium that is high or rapidly rising. Intoxication, especially with certain alcohols and drugs. O stands for refractory fluid overload. And U for uremia, for example, for pericarditis or encephalopathy due to uremia. We have also long-term indications for hemodialysis, of course, the chronic kidney disease, and that leads to fluid overload, so hypertensive disease that is not treatable with medication or cardiac decompensation. For access, you have this decision tree. Is it a acute indication or a long-term indication? In both situations, you can first use, if you want, a central venous catheter. So there are non-tunneled catheters. There are tunneled catheters, uncuffed or cuffed. And in each case, you have at least two lumens attached to at least two ports. Red means the blood flow goes towards the dialysis machine, and blue means the blood goes towards the patient. An example for a non-tunneled catheter is the Sheldon catheter. It needs no maturation, you can use it immediately, but it has a short duration of use, like about 2 or 3 weeks, and it has a higher risk of infectious complications. The implementation size is variable, mostly in the internal jugular vein. You can also implement it in the subclavian vein, or if needed, in the femoral vein. But if possible, avoid femoral access, especially in patients transplanted or immunosuppressed, because of the higher risk of infection. Concerning infection risk, Olivier et al. Showed 2000 in a publication of a prospective study published in Kidney International called Risk of Bacteremia from Temporary Hemodialysis Catheters by Site of Insertion and Duration. He could show the following results I will present you. First, bacteremia was defined as positive blood culture and positive cultivation of catheter tips. So here you see the diagram with the two lines. For femoral insertion, you have this, and for internal jugular insertion, you have this point of a probability of 5% to have bacteremia. That corresponds 7 days in femoral positioning and 21 days in the internal jugular positioning. That's also the guidelines, more or less, how we are taught the length you may leave those catheters. For a tunnel catheter, there is the example of a perm cat. It also allows immediate use. Its duration is a little bit longer. It is like an intermediate or long term sometimes. The patency of 1 year is 74%, and in 2 years 43%. And it has a lower rate of infections than the non-tunneled catheter. Next, we go to the field of arteriovenous fistulas, most interesting for us in the department of surgery. They are preferred for long-term use because they have the lowest incidence of morbidity and also infection rates, and they have a significantly higher long-term patency rate. But they need time. They need time for maturation, so you have to plan them 6 months ahead, and the minimum maturation time is 4 to 6 weeks. The longer period you have for maturation, the lower the risk for sepsis and mortality. Here you see the sites where you usually perform those arteriovenous fistula. Not anymore so used the snuffbox arteriovenous fistula because it has a low patency rate, but very common the radiocephalic fistula, number 2, number 3 the brachiocephalic fistula, and number 4 the brachiobasilic fistula. The gold standard for all arteriovenous fistulas is first, if patients sit, it should be accessible sitting. First, you try it in the forearm and it should be radial. And if you try it in the upper arm, it should be anterolateral. Also very important, the last point, proximal vein patency must be assured. So not only clinically, but you have to verify with sonography that the venous blood flow is given, otherwise it has no chance to work. It will close by thrombosis. So here again, start distally and go proximal. The reason is exactly the one I said. If you start distal and it's not working, you can always go a step more proximal. So you start with the radiocephalic fistula, then you go to a brachiocephalic fistula and brachiobasilic. Imagine you do a brachiobasilic at first and it's not working, then you have a problem with your runoff and you can't go distal anymore. Does any resident know what the Cimino shunt or Cimino brescia fistula is?
It is a fistula between the arteria radialis and the vena cephalica.
Exactly, as shown before, the first option. Here you see it's a side-to-end radiocephalic anastomosis. Exactly. It was performed on first time 19 February 1965 by Dr. Appel and published a year later by Brescia, Cimino, Appel himself and Hurwitz. It was performed, if possible, in the non-dominant hand. Especially during dialysis, they wouldn't be able to use their dominant hand for 4 hours. That's the main reason. And it needs a physical evaluation before. So how is the skin looking? Is there any problem over there? And you do the Allen test. And mandatory also a sonography of the vein status. Next level would be the brachiocephalic fistula. Here you see an example from our clinic, a side-to-end brachiocephalic anastomosis. This fistula is a very common fistula, but it can lead to vascular steal syndromes. So often can produce hand ischemia, but it can also make some fancier stuff like ischemic monomelic neuropathy, especially of the nervus medianus. That's a lack of perfusion of the vasa nervorum from the nerve. So patients have loss of feeling or dysesthesia. What can you do then? You can perform a narrowing of the inflow. You can perform a drill or RUDI. Drill is a distal revascularization and interval ligation, and a RUDI is revision using distal inflow. Or, as last option, you can perform a shunt ligation and a new shunt more proximal. We have also an example in our clinic of brachiocephalic fistula of a young patient with a very high flow of 2.3 liters. He was symptomatic. He would have a hand that would fall asleep or sometimes headache, especially if he would turn his head bent down. So what did we do? We made a narrowing of the vein by a running suture, but if you leave it like that, recurrency is duty. So you have to pack it and reinforce it, and we did that with the bovine pericard patch. Flow afterwards was 600 milliliter per minute, exactly as we want. Wheel et al. Showed in 2008 in a study where he analyzed primary patency. He showed, for example, in a radiocephalic fistula, that first, the primary patency is not really good. After 1 year, it's about 40 or 50%. That explains that you redo arteriovenous fistula in the lifetime of a patient multiple times. But secondly, he showed that patients that are over 80 years have an equal outcome to patients aged 65 to 80, which means you should also provide those people with chance if needed and not use age as a reason not to perform a shunt. It could also be showed the same result for brachiocephalic fistula. So the message is not a really high primary patency at all, and you should offer it also to elderly patients. Next level would be the brachiobasilic fistula. There is a 1 or a 2-step procedure. Here in our clinic, we prefer the 2-step procedure, meaning first you create an arteriovenous fistula, and only if the maturation is there, you perform in a second step the basilical vein transposition to anterolateral. This because it's more traumatic, or the traumatic part of this operation, and if there is no maturation, you did it all for nothing. Here also a picture intraoperatively where you see how it's done. Last but not least, there is also the possibility to use arteriovenous grafts. And their indication is mostly a failure of a AV fistula or comorbidities, especially inadequate anatomy, no veins, or obesity. They are always there and left as a last option. They don't need any maturation. Most common anatomical location is the forearm, followed by upper arm, and then you have also some fancy places. You will see you can put a graft nearly everywhere. Here, for example, the more common, the brachioaxillary interposition graft, or also a brachiocephalic loop graft. Then you can have those variations or even more extensive graft positioning. Grafts usually are out of 3, you can choose out of 3 materials. Either they are prosthetic, most is PTFE, polytetrafluoroethylene, or they are allografts, for example, cryopreserved femoral vein or artery, or they are xenografts. You can use bovine carotid artery or mesenteric vein. For AV fistulas and AV grafts, there are on one hand the local complications that can occur, like bleeding, seroma, or neuropathy, as I told you, on Steele's syndromes. And important here to mention is if you have an infection. If you can show it's in a staphylococcus infection, they mostly create a biofilm. So if it's a AV graft, you need to remove it. But there are also systemic complications to AV fistulas or grafts. And this is explained by the saying it's a high flow, low resistance system, so a big blood flow. So you can have a systemic vascular Steele. You can have patients suffering from a symptomatic like a coronary ischemia. As I said, the patient before had the flow of 2.3 liters. If you assume in a calm position, a patient has 5 or 6 liters a minute pump function of the heart. There are also cardiopulmonary problems in general, like cardiac decompensation or pulmonary hypertension, and you can have systemic infections. Al-Masri showed in 2016, or this systematic review and meta-analysis I want to show you quickly. He showed, looking on studies published between 1970 and 2014, that would include at least each study 10 patients and would refer to long-term hemodialysis on AV grafts, AV fistulas, and tunnel catheters with the primary interest of primary patency. That, as I said before, the AV fistulas have the best results. So number 1 is in violet, the brachiobasilic fistula. Number 2, the most used by us and where you should start, the radiocephalic fistula in green, then the brachiocephalic fistula, and at last the arteriovenous grafts that have, as you see, a really low primary patency. Summary to my talk is, if you have the indication for a long-term hemodialysis, gold standard and choice should be arteriovenous fistula. Always start distally or distal. With the radiocephalic fistula, going then to a brachiocephalic and brachiobasilic fistula. Plan it with enough time in advance, like 4 to 6 months, and always evaluate for a kidney transplantation. Here I want to leave a statement from our department. For us, it's important that at least a transplant surgeon is involved or is performing the vascular access since he would see the patient in a follow-up and always re-evaluate for a kidney transplantation. We are the only clinic in Switzerland where mainly or nearly exclusively transplant surgeons perform those fistulas. That's it, and I thank you for your attention.
Richard, thank you very much. I think what you said at the last point is very important. We always have this discussion, who should do the fistulas, and I see in the patient's perspective, it's important to see the patient as a whole. Does he need a PD catheter? Does he need because there's other possibilities of dialysis or hemodialysis or kidney transplantation. And this originates from the time point when you see when the Chimula shunt was developed. That's when the kidney transplantation was developed, this mid-60s and 60s. So that's why this many transplant surgeons in the US and the UK do the access for dialysis. So are there any questions?
Thank you, Richard, for this nice talk. My question would be, what is the role of interventional radiology in establishment of a fistula? Is it feasible with magnetic anastomosis or other techniques? Or
Yes, I have an extra slide where I can show you. We work together with our interventional radiologist, Professor Van Matter, and he now is trying the Everlin Q system. Mostly you can use it when a primary fistula is not feasible distally because you have too small veins. So before you do a proximal surgical access, you can use this system. So you go with two catheters, one in the brachial vein, you have two, and one in the brachial artery. Then those catheters, they look like this. They will turn around by itself. They are magnetically guided. When you control on angiography the correct positioning, you then make out an electrocauter come out, and he will make an incision with the creation of a hole, and thus creating an arteriovenous fistula. And then when you leave, you additionally put a coil, or you just close this brachial vein, so the backflow is less. And after some time, you then have over the fistula maturation of the whole superficial or epiphyseal veins, and the goal is then that, for example, the cephalic vein grows enough and you can perform hemodialysis. So that's a new option we have if we don't, or we are not performing AV fistula distally. Yes.
So just to say, there's not much results yet, but what is very important is when you go into doing fistulas, you need a good interventional radiologist, because you see that 50% non-patency after a couple of years. So, and most complications will be treated by your interventional radiologist. So if you go in this field without interventional radiology, you will lose. And this is why our interventional radiology, and we work hand in hand, and we discuss every patient in a vascular access meeting, because it's very important. This new kind of fistula, I think it's promising, but we don't have any results yet.
Okay.